I'd like to introduce Rob. Rob Entrekin is a senior clinical scientist in our ultrasound team, and he's going to share with you couple technologies or ways to really look at identifying the plaque burden earlier in coronary artery disease patients. So, Rob?
Thank you, Lori. I'm a biomedical engineer by training, and in fact, Dr. Patel, I did my graduate work at Duke University with the BME department on the first cardiac phased array scanner with Joe Kislow. So I have a soft spot in my heart for Duke. I am a clinical scientist, as Lori mentioned, in Philips Ultrasound in Seattle. And my colleagues who are also on the call today are Antoine Collet-Bion and Laurence Rouet, and they're both senior scientists at Philips Research, located in Paris. I'd like to talk to you today about three concepts for how ultrasound might contribute to earlier detection and improved risk stratification for coronary artery disease, and get your thoughts and feedback. As we all know, atherosclerosis is a progressive and systemic disease that affects all major arterial territories, but coronary atherosclerosis is the most significant because it's the largest cause of morbidity and mortality worldwide. The most accurate methods for diagnosing the extent and severity of CAD are usually indicated only after a patient becomes symptomatic or has a major cardiovascular event. So the challenge for primary prevention has always been to find a non-invasive and accurate method to identify asymptomatic patients at high risk, so that early intervention and treatment can prevent that first heart attack before it occurs. Many studies over the past 20 years have shown that ultrasound can detect and quantify subclinical plaque in the carotid and femoral arteries, and that this peripheral plaque burden is an independent risk factor that's predictive for CAD and major events. The evidence for this is sufficiently strong that several medical societies, especially the European Society of Cardiology, have adopted clinical practice guidelines that recommend ultrasound for the assessment of carotid or femoral plaque as a risk modifier in patients who have certain comorbidities such as hypercholesterolemia or diabetes. So at Philips, we ask ourselves, how could ultrasound be used to implement these guidelines and help improve early detection and risk stratification for CAD? We've been exploring three concepts. The first idea is to use point-of-care ultrasound in an office-based setting for early detection of carotid plaque as a biomarker for CAD risk. The second idea is to use 3D ultrasound for precise quantification of peripheral plaque burden for better risk stratification. And the third idea is to use artificial intelligence to analyze 3D images and classify plaque composition with a kind of ultrasound virtual histology. So let me explain a little bit more about each one of these ideas. In the first concept, the cardiologist or nurse would examine the carotid arteries in an office setting with a handheld ultrasound like the Philips Lumify in order to screen for the presence or absence of carotid plaque. I should point out that this would not be a conventional vascular exam with dozens of annotated images and Doppler measurements. This would just be a simple survey sweep of the carotid from clavicle to jaw, recorded over 5 or 10 seconds. My colleagues at Philips Research have been developing AI-enabled image processing software that can automatically identify the artery wall and plaque in each frame and measure the maximum plaque thickness in that segment of the artery. A study published in 2018 in the European Heart Journal by Sillison showed that in a cohort of 5,800 asymptomatic American adults, a maximum carotid plaque thickness greater than 2.5 millimeters predicted future cardiovascular events at a rate that was 3 times higher than those with no plaque. Also, in a 2019 Lancet article, Naslund reported on a study of 3,500 Swedish adults with one or more conventional risk factors. They demonstrated that just showing the patient a picture of their carotid plaque improved patient compliance with lifestyle modification and medication, and significantly reduced their Framingham risk score at 1-year follow-up. So we think this simple office-based approach could be beneficial for identifying patients at higher risk for CAD and for helping them modify their risk factors. In 2019, Philips developed a 3D vascular transducer for the Epic Elite ultrasound system. This fully electronic matrix transducer captures a volume snapshot of the iliofemoral or carotid bifurcation in a fraction of a second. And this 3D snapshot, along with some deep learning software, can reconstruct a geometrically accurate 3D model and precisely quantify the plaque volume in the region around the bifurcation. Another study published in JACC in 2015 by Fuster showed that in a cohort of 6,000 asymptomatic American adults, both coronary calcium score and carotid plaque burden were equally predictive for major cardiovascular events in a 3-year follow-up. So we think that quantification of plaque burden with 3D ultrasound can provide useful information for predicting cardiovascular risk. In the third concept, we're using deep learning algorithms and training them to analyze the grayscale statistics and texture of the echoes from inside the plaque in order to classify its composition. Previous studies have shown that echogenic carotid plaques are associated with stable components like calcium and fibrous tissue, while echolucent plaques are associated with unstable components like lipid-rich necrotic core and intraplaque hemorrhage. So if we're successful, this virtual histology approach could be used, for example, for monitoring changes in plaque composition in response to lipid-lowering therapy with statins, PCSK9 inhibitors, and other drugs. So at this point, I'm happy to answer any questions you might have, and I also have some questions for you.
Well, I think that this system where you can use it in practice, point of care setting is extremely useful. And I'm impressed by the study, and I was an editor of the European Heart Journal at that time, that shows actually how it can have an impact for patient compliance, for patient understanding of the disease process. And I would certainly say that pictures say more than 1,000 words, as the Chinese said. And insofar, that's very, very interesting. And of course, the other system is more for research purposes, I guess. In clinical setting, you're not that interested in such a precision because the management that is derived from is usually quite standard, independent on this deep insight into the structure, but for academic purposes, extremely interesting indeed.
Professor Luscher, if we hear you well, what I hear you saying is that for the overall clinical practice, it's very appealing, the thought of having early detection being done outside of the echo labs, right? Thinking about bringing echo to other realities. But at the same time, the quantification and the ability of going further in that detail will be interesting in the academic settings and perhaps provide more data for the future. Is that a fair assessment of your view?
Absolutely. But I mean, most patients are seen by GPs, and the simpler the tool is, and the more affordable, the more it will be used. And prevention obviously is better than cure, particularly as regards atherosclerosis.
I have two questions. One, which is pretty general, and that is, I'm impressed or interested in the use of AI to categorize and classify plaque composition. Are you, at the same time as you're doing this from an ultrasound perspective, are you using AI for CT angiography, where I think everybody would like to characterize plaques in terms of their vulnerability? And so plaque characterization, I think with CT and other techniques is really a very hot topic at the moment. And are you adapting AI to that? So that's one question. And then, sorry.
I said, okay, I got it.
Yeah, and then I'll follow up. I'll follow up with the second question in a moment.
Okay, yeah. So the short answer is that, we're in the ultrasound group here. We're focusing on the ultrasound application, but we have been working with some of our clinical partners where we're doing both CTA and 3D ultrasound at the same time on the same cases, and trying to apply the same tools, at least for the segmentation of the plaque burden. I don't think that we've gotten into the classification of composition from the CT side at this point. We've been really looking at the ultrasound, sort of virtual histology for plaque composition. So the short answer to your question is no, we haven't looked at the CT composition.
Yeah. So the second, given as I look upon our own experience at Mayo, where we have a very active AI group in cardiovascular medicine, and we've really focused at the moment on the 12-lead electrocardiogram and what we can learn from that. But I have learned one thing, and that is it may work in one group of patients. When you take the same algorithm and you take it to a slightly different group of patients, you can't predict its efficacy at all. You have to revalidate everything all the time. So what may be useful in a carotid plaque may not apply to plaque in the coronary.
Yep.
Second question, really, or issue I want to raise is, have you really given a lot of thought to not just the technology, but how you're going to validate it in terms of the large patient populations? How are you going to demonstrate the incremental benefit of this additional data?
Yeah.
Because that is a huge issue.
Yep. Yeah, no, absolutely. And I think that that's really sort of the elephant in the room is, what is the real value of this early detection? Is it really going to make an impact in terms of outcomes? We've shown sort of in some of these studies that have been published by some of our clinical partners that there's strong correlation, but we haven't done, a prospective study to demonstrate that there would be a benefit for this type of early detection. There are population studies that are currently underway. For example, the PACEF study in Madrid with Dr. Fuster's team at the National Cardiovascular Center in Spain. They're doing exactly a large population study. I think they have about 4,000 participants. They've been following them already for 6 years, and they're going to follow them, I think, for a total of 20 years, if I'm not mistaken. So I think you raise an important question, Dr. Gersh, and I don't have a good answer for you, but I think that's one of the reasons why we want to provide the tools like this plaque quantification tool to support the academic research, so we can start to get some of the answers to those kinds of questions.
Rob, I see that Dr. Patel and Professor Kirchhoff have their hands up.
Yep.
I think I saw Dr. Patel first.
Yeah, just a comment before we move on, just to finalize what Rob was saying. Those studies are really ongoing with that level of understanding that this has to show beyond the patient population that is somehow already recognized on highest risk of having benefit of this early identification of plaque, and then the image having impact on behavioral change. And with the work that Dr. Fuster has been doing, it's really to go earlier on in asymptomatic people, so not patients, population, and to understand how that can be impactful. And so from then it explains also the ambition for the 20 years follow-up, but how can we make that more target, and which patient population can we bring on so we have results earlier? And that would be part of the good understanding from this conversation also, so from your guidance.
Yeah, this Manesh is going to give some comments. I guess I'll start by saying I'll ask some questions that might sound crazy, but I wonder if we should be making sure we're speaking of the same things. So, is peripheral artery disease and coronary artery disease the same disease? I asked that question because imaging the periphery, you're assuming you're going to identify rates. And I know patients are at a higher rate for coronary events, but what our clinical trial experience has been is that people with peripheral artery disease who get later in life who haven't had a coronary event don't have coronary events. But those that have had a coronary event, they may eventually develop the atherosclerotic burden. So the idea of improving events in patients early in life hinges on a term that we've been using more recently, and I think you had on one of your slides, called asymptomatic high-risk subclinical atherosclerosis. And I would postulate that to prevent events in a certain bed of vascular disease, identifying those patients that have the high-risk features in that vascular bed will be an important tenet. I say that because we've carried out large PAD trials recently, coronary trials, CT angio trials. And what we see is that, for example, in the Euclid trial, if you had PAD patients, but they did not have coronary disease, at least clinically, so 100% PAD patients, 14,000 of them, 30% had coronary events. Stronger antiplatelet therapy didn't change the outcomes, and those patients didn't have coronary events unless you did something to their coronary system. The same thing is actually true in Voyager, a recent study with rivaroxaban low dose. I can imagine there's a variety of therapies, inclisiran, Lp(a), other therapies coming where having this information would be very valuable. But I suspect when we talk to them, the valuable information is going to be valuable if it's in the bed where the events you're trying to prevent occur. So a carotid might be very important for cerebral events. The periphery may be very important for limb events. But the assumption, just because the lifetime risk is high, is that you're going to stop an event in the coronary tree, I think is an assumption we should be questioning.
Can I just respond to that quickly? I completely agree with that, Dr. Patel. I guess one of the ideas here is that if you do see significant peripheral plaque burden, does that then raise the level of suspicion that might trigger, a coronary calcium scan or a stress test to try to rule out CAD or rule it?
Yeah. So we have some data, which is, I think, important, which is, I think, Dr. Fuster's level of data that you're thinking about. Atherosclerosis does seem to happen first in this sort of iliofemoral area. And it seems like if you're measuring people chronically, that's where it seems to happen first. What's unknown is the progression from that location to carotid to coronary and when the features are of the patient, when it may go to different beds. And so the number of degrees of freedom you have to go from saying, I'm going to test it and give it to you as a tool for the femoral evaluation or the carotid evaluation, then you must do a coronary evaluation. I'm okay with, I'm just thinking about how you're going to enrich that. And then I also think about just the barriers, at least in the United States, of giving someone a tool, asking them to do something without a clear funding mechanism and a clear treatment algorithm. Sure.
No, that's understood.
Right. Well, thank you. Really interesting technologies. I wanted to follow up a bit on the point of care device. I think it's a very intriguing thing. I mean, in the end, even last year, there died more people of cardiovascular diseases than of COVID in the US, despite the probably then biggest net of CTAs and advanced cath labs and cardiac MRIs and what have you. But I think in the area of early detection, you're competing with two other strategies. One is what I have learned in the UK. You basically give a statin to everyone over 50, and that reduces cardiovascular risk, and you don't need an ultrasound for that. But the other one, which I think will be something that you will have to look into, and maybe you can explain that from that paper that you mentioned. Taking a blood sample is a lot simpler than even a point of care ultrasound device. And of course, we have cholesterol. And there are good data that very low chronic elevations of troponin or BNP actually predict cardiovascular risk very well. And there are a few emerging blood biomarkers that will probably be ready for clinical use in a few years' time. And I wondered whether you have compared your ultrasound point of care prediction with any of these approaches, which are probably, if they have the same precision, easier implemented at scale than handing out point of care ultrasound devices.
Yeah, understood. The short answer is no, we haven't done that comparison, but it's a completely valid point.
Maybe a short comment. I share many of the comments of my colleagues. I think we have clearly two different levels here. One is a more clinical level, what is ready now to be implemented and what is easier to be used by most clinicians. And that's, of course, the first one with the point of care ultrasound, which is becoming more disseminated and more used by, although it's still in a way a change in mindset for many clinicians, but it's like a new stethoscope. Here will be it will be a twist because it's going to be using in the peripheral arteries, which, and that was mentioned by previous colleagues, it's basically a marker of atherosclerosis. And that's actually why in the guidelines, particularly in the prevention guidelines, now it's a little bit more reinforced its use, because it's basically helping to classify the patient in very high or low risk, and that will determine the strategy in terms of the aggressiveness of controlling the risk factors. So that's one part. The second part, of course, is a lot of what, in particular, the second component, and the use of AI, which is inevitable, and AI is everywhere now. It's a big business also, by the way, with all these new apps and new potential uses from ECG to all different elements. But I think we all agree that this is it's not only the future, but it's the present already. I've seen amazing things now with the use of AI, and that makes sense because using millions of points and millions of data, it's natural that we will have more information, and data is information, and the more we have, the more information we'll get. But one of the issues that was raised by Dr. Gersh is very important, because it's validation. And sometimes you may have, and we've seen that in medicine, that beautiful things, and then for some reason they don't work. So that second component, which makes a lot of sense, that is something that we've been. I remember 30 years ago when I started doing ultrasound, there was one of the big things, tissue characterizations to define plaques, and then with CT, with ultrasound, MRI. I would say it's very interesting work, but that second part, I still think there's a long way to go. For the first one, it might be easy, it might be useful. But again, and I know there are different practices in different parts of the world, but it may make more sense, and it's ready, basically, and it's a concept that it's easily understood. It's just a matter also of education. That's the other thing, because you need to educate, because one thing is what we are discussing here. The other thing is the level of, let's say, the general cardiologist or GP that's potentially going to use this. And that the other thing, which is your second question, there are also some legal considerations on the use of this type of devices in different parts of the world,
sure.
Which you can use just as if you want an extension of the stethoscope. As you know, it's one of the things that has been discussed in many parts of the world. If you should consider this as a procedure, or if it's just an extension of physical examination. And of course, this has a lot to do with billing and so on. So these are my initial comments.
Thank you. Thank you.
I just wonder about, again, to go back to how are you going to validate the incremental value? And you don't want to wait 20 years. And one population that, as you start to think of studies that you may wish to do or support, the one group may be people with homozygous familial hypercholesterolemia.
Yep.
Where you are faced with the decision of a 28-year-old with this familial history who has no coronary disease, and are you going to start them on a statin at a very, very young age? And that may be a group to think about, where you perhaps will get results over a much shorter period of time, because that also is a group where the biomarkers that Paulus talked about may also be helpful. And it's just something I think you might consider.
Thank you.
That's a brilliant thought, Bernie. I'm working here with a few epidemiologists or epidemiologically minded cardiologists in Hamburg, and I keep learning that the predictive power, the accuracy in high-risk populations is completely different to the general population. So you may actually want to validate this in a population-based study where biomarker concentrations and clinical information is available. And these, I mean, Framingham doesn't do the trick this time, but there are cohorts like this, epidemiological studies ongoing that have the bio samples that you would probably need.
And I was triggered by your comment, Paulus, of saying that a blood sample is easier than this. I would challenge that thought, right? Because a blood sample is somehow invasive. It's not also available everywhere, and people are afraid of needles. This is supposed to be something really quickly. So, does everyone think the same, that a blood test is easier?
I'll elaborate on that. There are millions of people around the world who are trained to take a blood sample. There are established logistics to get a blood sample to a place where it can be analyzed and where the result can be fed back. If you take a blood sample in Africa and ship it to Hamburg and then measure it in Australia, you'll get the same result everywhere. Whilst even if you read an ECG, you'll probably get different interpretations, even if you ask really good experts. So I think there's a lot to be said about blood samples, but yes, from the patient perspective, it may be less convenient than an ultrasound, but in terms of a standardized, scalable, worldwide available test, it's probably even better than a clinical history.
Yeah, so from what I hear from you, you are also telling us by other words that this has to be automated. This cannot depend on the individual expertise of whom is getting the data. Is that fair?
I would. I don't know if I agree with. I mean, I don't know that it has to be automated. I think what I hear Paul is saying, and what I thought of is that changing behavior is hard, right? So fundamentally, right now, we're trained to send patients to a lab. They get a lab draw for their cholesterol, and then we do things. If you added on something to that blood draw, then it wouldn't be a huge change in behavior. If you ask primary care physicians or cardiologists to scan the carotid, I'm not suggesting that's a bad idea and it won't motivate patients, but changing that behavior and then having an action that leads to, as Bernard has said, like an incremental benefit for that patient or a decision, those are high bars. Changing behavior, if you could work it in the current pathway, or you could have something that was a carrot or a stick, would work. But changing the behavior without clear evidence that it changes outcomes, and a variety of ways in which people might misinterpret that. So the automation does matter and how they interpret that.
I wouldn't
say that everybody discusses now blood versus ultrasound. I think that's completely the wrong way to look at this. I mean, of course, troponin predicts outcome in BNP, but look at the scatter; it's enormous, and that's why we moved to artificial intelligence, because we have to incorporate lots of parameters. We're doing also artificial intelligence after ACS with lots of lab values and you name it. And I think imaging is incremental in prognostic value, because even if you have a cholesterol of 4.5 LDL, not everybody develops a plaque. I mean, they're resilient people. And if you have a plaque plus the lab values from blood samples, then you're really talking. And that, of course, then leads to management decisions, obviously. But of course, this has all to be developed. But I think we want to integrate in our future practice demographics, history, blood sample tests, and imaging.
There is one additional.
We are at time on this topic, so we have time for just one more comment, Professor Pinto, from you, and then we'll switch gears.
No, one additional argument in favor of imaging is that you have an immediate result. With the blood sample biomarker, of course, important, but you don't have that readiness, immediate response. If you're gonna scan somebody, the result is immediate, and that may play a role here. But I agree with the comment of Tom that you will need, and particularly now that we still have a lot of open questions, I think you will need all these different elements. But I would say that imaging, because of the readiness of the result, the immediate result you have, you can take it to the bedside outpatient clinic. it's in a way it's an easier way to do it, even if you have, and that's true, because in some cases you may have the problem of operator dependency, but that's something that education should be is here a point as well.
Wonderful. Thank you all for a really dynamic discussion about this, and thanks, Rob, for your presentation.